Our mission today is pretty simple.
Yep.
To unpack the origin story of ATLS, understand its massive global footprint, systematically break down its core approach, that famous ABCDE, touch on how these principles scale up to triage, and ultimately understand why mastering this systematic framework straight from the sources you've shared is so critical for anyone in your position. We're sticking strictly to the content within these texts.
Exactly. We'll be your guides, helping you see the most important nuggets of insight from these foundational trauma resources.
So let's jump right in. Why is having a systematic approach to trauma care even necessary in the first place? I mean, the sources paint a pretty grim picture of the global burden of injury.
They really do. When you look at the data cited from organizations like the World Health Organization and the CDC within these materials, the scale is sobering. We're talking about more than 9 people dying every minute from injuries or violence worldwide.
9 people a minute. That's...
Yeah.
Wow. That's almost unimaginable when you hear it like that.
It is. It adds up to 5.8 million people lost each year, and injury accounts for a staggering 18% of the world's total burden of disease. It's not a minor issue. It's a massive global health challenge.
And focusing specifically on motor vehicle crashes, which the sources seem to highlight quite a bit.
Yeah, motor vehicle crashes alone are just devastating. They cause over 1 million deaths annually and are estimated to result in, get this, 20 to 50 million significant injuries.
50 million.
The sources point out they are the leading cause of injury death worldwide and the leading cause of death for persons 1 through 44 in most developed countries.
But there's a significant geographic disparity mentioned there too, isn't there? That seems important.
Absolutely, and it's critical. Shockingly, over 90% of these motor vehicle crash deaths occur in the developing world. Projections mentioned in the materials showed an expected 80% increase in low and middle income countries by 2020 compared to previous rates.
An 80% increase.
Yeah. This isn't just a statistic. It highlights an immense, urgent global need for standardized, effective trauma care where resources may be most limited. It's clear the problem requires a systematic, teachable solution.
That makes perfect sense.
Cool.
So faced with that kind of global burden, where did this systematic solution, ATLS, actually come from? The sources give us a very specific origin story. It wasn't like a government mandate or cooked up in some big academic lab initially.
No, exactly. It wasn't a top-down directive or a single laboratory discovery. The need was identified by a group of individuals right on the front lines, primarily in Nebraska. We're talking about private practice surgeons and doctors working alongside the Lincoln Medical Education Foundation, the Lincoln Area Mobile Heart Team nurses, and supported by institutions like the University of Nebraska Medical Center, the Nebraska State Committee on Trauma of the American College of Surgeons, and Southeast Nebraska Emergency Medical Services. A real collaboration.
So a truly collaborative, ground-up effort stemming from a recognized problem on the ground.
Precisely. They saw inconsistencies in trauma care outcomes, particularly, in rural settings where immediate access to specialized trauma centers might be delayed. The sources describe this group identifying a critical need for training in advanced trauma life support principles that could be applied quickly and effectively. They didn't just talk about the problem, they built the solution.
And what did that initial solution look like? How did they structure it?
Well, they formed the prototype ATLS course. The sources describe it as a combination of lectures laying out foundational knowledge, but also, importantly, hands-on skill demonstrations for critical life-saving procedures and practical laboratory experiences.
Okay.
The focus was intensely practical training providers how to assess and manage severe injuries in a standardized, prioritized way. It grew directly out of the need they witnessed firsthand.
That's a powerful origin story born from necessity, developed by practitioners, and built around practical skills. And this idea, starting small in Nebraska, clearly went global. The sources really emphasize its broad success and impact on healthcare systems worldwide.
Oh, it has had an undeniable positive impact worldwide. The sources highlight how it's improved the skills and knowledge of healthcare providers across the globe. And what's particularly significant, I think, is the statement that its success in creating a large pool of providers who understand core injury care principles, both within the U.S. and internationally, has been absolutely instrumental in the implementation of trauma systems themselves.
So it's not just training individuals, it's helping build the actual infrastructure for trauma care. That is a big claim.
It is, and the sources support it. Especially in many low and middle income countries, ATLS hasn't just provided training. It's given both the impetus to improve trauma care and the basic tools needed to even begin constructing a system.
Okay.
The widespread adoption of this knowledge creates a common set of principles and, importantly, a common language. This shared understanding acts as a crucial cohesive force, helping bring together different components of a trauma system, from pre-hospital care to smaller hospitals to specialized centers. It promotes minimum standards of care, ensuring that patients receive a baseline level of effective, organized treatment regardless of where the initial care is delivered.
That concept of a common language in the chaos of trauma care makes so much sense. Okay, so at its heart, ATLS provides the systematic approach. What are the fundamental premises, these core guiding principles, outlined in the sources that underpin the entire protocol?
Right. There are three key premises that really drive everything in ATLS. First, and perhaps most critical, is to treat the greatest threat to life first. You deal with what's going to kill the patient fastest, right now.
Priority one.
Priority one. Second, indicated treatment must be applied even if you don't have a definitive diagnosis yet. In trauma, you often can't wait for every test result. If the signs point to a life threat, you treat it based on probability and urgency.
Act now, diagnose fully later.
Exactly. And third, you don't need a detailed history to start the evaluation and treatment. While history is important later, the immediate priority is assessment and intervention based on physical findings and vital signs. You have to act quickly.
Those principles really underscore the time-sensitive nature of trauma. And these principles lead directly into the two main phases of assessment we hear about, the primary and secondary surveys.
Exactly. The ATLS approach divides patient assessment into these two phases. The primary survey is where you diagnose and treat life-threatening injuries simultaneously. You're constantly assessing and intervening to stabilize the patient. Everything else less immediately life-threatening injuries is evaluated in the secondary survey once the patient's condition has been stabilized, or at least you've addressed the immediate threats.
And the primary survey is where you encounter that famous mnemonic ABCDE. Let's really dive into that, breaking down what each letter represents and what the sources highlight as critical steps and maybe potential pitfalls, starting with A.
Okay. A is for airway maintenance with cervical spine motion restriction. The sources are very clear. If a patient can talk, their airway is likely not immediately obstructed.
Likely, but not guaranteed.
Exactly. But that's not a guarantee, and you must reassess constantly. A key threshold mentioned is a Glasgow Coma Scale, GCS score of 8 or lower, which usually indicates the need for a definitive airway, such as an endotracheal tube, because their protective reflexes may be compromised.
So how do you initially manage an airway if it's not clear they need a tube right away? What are the first steps?
Well, simple maneuvers can be life-saving initially, like a jaw thrust or chin lift to open the airway, especially if the tongue is obstructing it. The sources also mention an oropharyngeal airway for unconscious patients without a gag reflex.
Right, need to check that reflex.
Crucial. But the core message is, if there's any doubt about their ability to maintain a patent airway, you establish a definitive airway. And throughout this, you always restrict cervical spine motion if a spinal injury is suspected, which is basically assumed insignificant trauma until cleared.
And the pitfalls here, what do the sources warn about specifically with the airway?
The main pitfalls highlighted are failing to recognize the need for an airway intervention early enough, incorrect tube placement or, displacement of an airway that was previously secured. It's not just about putting it in, it's about making sure it stays in the right place.
Makes sense.
The sources also make a practical point that having well-known and regularly used equipment available is often more effective than having the newest, most complex gadgets if staff aren't proficient with them. Stick to what you know works and you can use reliably.
Good practical advice. Okay, A is covered. What about B? Breathing and ventilation.
B focuses on ensuring effective breathing and gas exchange. Here, you're rapidly looking for and treating immediately life-threatening conditions like tension pneumothorax that's air-trapped in the chest cavity, compressing the lung and heart, or a massive hemothorax, a large amount of blood in the chest.
Right, those need immediate action.
Immediate. Open pneumothorax or significant tracheal-bronchial injuries also fall into this category and require urgent attention. The sources emphasize treating a suspected tension pneumothorax clinically, often with needle decompression, before waiting for imaging because it's an immediate mechanical problem that can kill quickly.
So unlike A, where you might need a definitive airway device, B is often about addressing these mechanical issues or, lack of lung function directly.
Exactly. Less severe issues like a simple pneumothorax or hemothorax, a flail chest where a segment of the rib cage is unstable, or pulmonary contusions can certainly compromise breathing, but are typically managed after the initial life threats are addressed in the primary survey.
Okay.
The sources state that every injured patient should receive supplemental oxygen, ideally via a mask reservoir, to achieve oxygen saturation above 95%, which should be monitored with pulse oximetry.
Got it. What about identifying problems with ventilation itself, the gas exchange part? How do you spot that?
Yeah, that's a key point. A major pitfall is failing to recognize inadequate ventilation, not just the breathing rate. The sources advise monitoring respiratory rate, observing the work of breathing, are they struggling, and using adjuncts like arterial blood gases, ABGs, and capnography, measuring carbon dioxide levels and exhaled breath if available, to really assess ventilation.
Capnography is key there.
Very helpful. And here's a critical warning from the sources. Applying positive pressure ventilation, like bagging a patient or putting them on a ventilator, can turn a simple pneumothorax into a life-threatening tension pneumothorax if the chest isn't decompressed first. You need to be acutely aware of that risk.
Right, that's a huge potential complication.
Yeah.
Okay, moving to C. Circulation with hemorrhage control. This is where shock and bleeding become the main focus.
Correct. The sources define shock in this context as inadequate tissue perfusion. Pretty simple definition, but complex causes. The most common cause in trauma is hemorrhagic shock, meaning blood loss.
Right.
But it's important to remember non-hemorrhagic causes mentioned, like cardiac tamponade or tension pneumothorax, which we touched on under B, but critically cause circulatory compromise. You need a high index of suspicion for shock. Don't assume it's always bleeding.
Good point. Where does significant blood loss hide in trauma patients, according to the sources? The obvious bleeds are one thing, but internal.
Yeah, the sources are quite specific about potential locations for large internal bleeding. Significant blood loss can occur into major fracture sites. They say up to 750 millirels in a tibia or humerus fracture.
Wow, just from a limb fracture.
Yeah, and a substantial 1,500 millirel with a femur fracture alone. Liters of blood can be lost internally with pelvic fractures or into the retroperitoneum behind the abdominal cavity.
Huge volumes.
So controlling external bleeding is also paramount and often straightforward. Direct pressure is the first step. For massive external extremity bleeding, the sources mention the use of a tourniquet as a life-saving measure. And for pelvic bleeding, which can be devastating, a sheet or pelvic binder applied tightly is noted as a method to help reduce pelvic volume and maybe tamponade some venous bleeding.
Okay. What about fluid resuscitation? How much and what kind of fluid do the sources recommend initially?
The guidance is to give an initial warmed isotonic fluid bolus. For adults, that's typically 1 liter. For pediatric patients under 40 kilograms, it's 20 millirel kilograms. Warming the fluid is important.
Right, to prevent hypothermia.
Exactly. After giving this bolus, you immediately assess the patient's response. Do they have a rapid response? A transient response, they get better, then worse again? Or no response at all? Their response really dictates the next steps in fluid therapy and investigation.
But the sources stress fluids aren't the ultimate solution if bleeding is ongoing. You can't just keep pouring fluid in.
Absolutely not. The texts strongly emphasize that persistent fluid infusion is not a substitute for definitively stopping the bleeding. You have to find the source of blood loss and control it, whether that's surgically, radiologically, or through other means. Stop the bleeding is the mantra.
Okay.
Also, the sources offer important considerations for specific patient populations, like the elderly. They may not show classic signs of shock like tachycardia due to medications or just decreased physiological reserve. Hypotension in an elderly patient is relative occurrent. A systolic pressure of 100 mmHg might represent shock for them, even if it seems okay for a younger patient.
That's a really important clinical pearl. And a key pitfall in circulation they mention.
A major pitfall highlighted is when a patient's shock doesn't respond to initial fluid resuscitation. The sources are clear. If they're not responding, you must actively look for the source of ongoing blood loss. This is where the mnemonic floor and four more comes in.
Ah, yes.
Referring to the floor, external bleeding, and then chest, abdomen, pelvis, retroperitoneum, and long bones extremities, common sites for large, hidden blood loss that needs definitive intervention. You also have to reconsider non-hemorrhagic causes of shock if bleeding isn't apparent.
Okay, we've covered A, B, C. Next is D, disability, the rapid neurologic evaluation. What's involved here?
D is about a quick assessment of neurologic function to identify major deficits. The core tool mentioned is the Glasgow Coma Scale, or GCS. The sources describe it as a quick, simple, and objective method, highlighting that the motor score component specifically correlates well with patient outcome.
So the motor score is particularly predictive.
Seems to be, yeah. Beyond GCS, you quickly check pupillary size and reaction to light, look for any lateralizing signs, like weakness on one side of the body that could suggest a brain injury, and attempt to determine a gross spinal cord injury level if suspected. It's a rapid screen.
What if the patient's level of consciousness is decreased? What's the immediate thought process?
The sources are very direct here. A decreased level of consciousness requires an immediate reevaluation of their oxygenation, ventilation, and perfusion status. You got to go back to A, B, and C. Hypoxia or hypoperfusion can severely alter mental status.
Rule those out first.
Absolutely. However, even if drugs or alcohol are suspected, you must presume a central nervous system injury until proven otherwise, as intoxication can easily coexist with severe trauma and mass underlying issues. Don't just blame the alcohol.
Got it. Presume the worst. And finally, exposure with environmental control. Seems simple, but important.
It is straightforward but crucial. The sources state you must fully undress the patient to allow for a complete physical examination. You can't assess what you can't see. They note this option transitions into the secondary survey.
Okay.
Critically, once exposed, you must immediately cover the patient with warm blankets to prevent hypothermia. The sources specifically mention this is especially important when administering warmed fluids during resuscitation, as patients can otherwise lose heat rapidly, and hypothermia really worsens outcomes in trauma. It's a vicious cycle.
So that's the primary survey. A through E, diagnose and treat immediate life threats simultaneously. Once those are addressed and the patient is hopefully stabilizing, you move to the secondary survey. What's the main purpose of this second phase?
Right. The secondary survey is your systematic, in-depth, head-to-toe evaluation to identify all other injuries that weren't immediately life-threatening or weren't fully assessed during the rapid primary survey. This involves a thorough physical examination, literally going from head to toe.
What areas does that detailed exam cover, according to the sources? It sounds pretty comprehensive.
It is comprehensive. You examine the head and maxillofacial region, the cervical spine and neck, reassessing stability again. The chest, abdomen, pelvis, perineum, and perform rectal and vaginal exams were indicated, and a detailed assessment of the musculoskeletal system, including checking the back by log rolling the patient. It's about finding everything else that needs attention after the initial resuscitation.
And this is where the adjuncts, the various diagnostic tests, play a bigger role than in the primary survey.
Absolutely. While some quick imaging, like a portable chest X-ray or pelvic X-ray, might be done during or immediately after the primary survey if the patient is stable enough, the secondary survey is where you more widely utilize specialized diagnostic tests. The sources list examples like fast-focused assessment with sonography for trauma.
The bedside ultrasound.
Exactly. A rapid ultrasound looking for free fluid in specific areas like the abdomen and around the heart. They mention DPL, diagnostic peritoneal lavage, though the radiology paper notes FAST has largely replaced DPL in many centers where ultrasound is readily available.
Makes sense. Less invasive.
Definitely. Plain X-rays and more detailed CT scans are also primary adjuncts for assessing specific injuries found or suspected during the physical exam.
And monitoring continues throughout this phase as well. It's not just examine and image.
Oh, crucially, continuous monitoring of vital signs, oxygen saturation, and urinary output is essential. The sources provide specific targets for urinary output. 0.5 millokVh for adults and 1 millokVh for pediatric patients over 1 year old as a key indicator of organ perfusion.
Good targets to remember.
And managing pain effectively, often using IV opiates, is also highlighted as an important part of care during this phase. Don't forget pain control.
Right. The sources also really stress that even after all this, the process isn't static. There's this need for constant reevaluation.
This is vital. Trauma is dynamic. As you manage initial issues, other significant injuries might become apparent, or a patient's condition can deteriorate unexpectedly. Maybe that simple pneumo becomes a tension pneumo later. The sources emphasize maintaining a high index of suspicion and continuous monitoring. ATLS isn't just a single pass, it's really a loop of assessment, intervention, and reevaluation.
Okay, that makes sense. Now, ATLS principles aren't just for individual patients. They also apply to triage.
Yeah.
Managing multiple injured people, like in a mass casualty event. How does the protocol scale up to handle triage situations?
Right. Triage becomes necessary, as the sources explain, whenever the number of casualties exceeds the medical capabilities immediately available. You just don't have enough hands or resources for everyone at once. The core principle of ATLS, treat the greatest threat to life first, remains the guiding light for triage decisions.
So you apply the same logic, just more people.
Exactly. You apply the same ABCDE priorities, but across a group of patients to decide who gets attention and resources first.
So you're rapidly assessing multiple people using that ABCDE filter to sort them.
Precisely. You focus on each patient for a very short period, making immediate determinations based on the greatest threat they present. The inherent prioritization in ABCDE is crucial here. Airway problems are generally more rapidly lethal than breathing problems, which are more lethal than circulation issues, and those are typically more immediately life-threatening than isolated neurologic injuries. This helps you quickly categorize patients who needs intervention now, who can wait a bit.
The sources mention something called the Zero Survey in the context of mass casualty. What exactly is that? It sounds like something before the primary survey.
Yeah, the Zero Survey is a concept specifically relevant in mass casualty or maybe austere environments, as described in the materials. It's essentially pre-arrival preparation.
Right.
It involves having an accurate inventory of your local resources, staffing levels, available expertise, equipment, facility capabilities, even environmental conditions like weather.
Knowing what you have before they arrive.
Exactly. Knowing your limitations before the patients arrive helps you make appropriate, realistic triage decisions and allocate resources effectively in what will undoubtedly be a chaotic situation. It's about planning ahead.
And the sources include hypothetical scenarios for mass casualties. What's the point of those in the training? Are they case studies?
They're not really there to give you definitive answers for every single situation, but rather, as the sources state, to help train providers in applying these ATLS principles under pressure. They illustrate the decision-making process required in complex situations.
The process.
Reinforcing how to use the ABCDE structure to prioritize and act when faced with limited resources and multiple injured people. It's about practicing the systematic thinking, not memorizing specific case outcomes.
Okay, that makes sense. Zooming back out now that we've walked through the core protocol and triage, why is getting this ATLS training so crucial for someone like our listener, maybe just starting their career in a demanding environment like the ER or surgery?
Well, the sources repeatedly and strongly highlight the value. First and foremost, it establishes an organized, systematic approach. When you're faced with a critically injured patient, perhaps for the first time, this structure is just invaluable. It helps you prioritize your actions in what can feel like an incredibly chaotic situation.
It takes some of the guesswork out, gives you a path.
It provides a reliable roadmap. Exactly. It also promotes minimum standards of care. By training a large number of providers in the same principles, it helps ensure a baseline level of quality in initial trauma management, no matter the facility. The training improves your skills and knowledge in managing acute life-threatening conditions in a timely, effective manner.
And you mentioned the common language earlier. That seems really key.
That common language is one of its most powerful aspects, I think. Having a standard set of principles and terminology among providers from the pre-hospital team to the ER nurses and doctors to the surgeons dramatically facilitates communication and teamwork.
Everyone's on the same page.
Exactly. In trauma care, where seconds count and multiple disciplines are involved, clear communication is absolutely critical. The sources point out that the course includes skill stations specifically designed to fine-tune performance in crucial procedures like airway management, chest tube insertion, or vascular access.
Practice makes perfect.
And ultimately, perhaps the most impactful claim the sources make is that the widespread implementation of the ATLS program has demonstrably contributed to reduced morbidity and mortality in trauma care globally. It saves lives.
This deep dive into your sources really reveals ATLS as far more than just a sequential checklist. It's a vital framework, isn't it? A system for prioritizing care under pressure, building essential skills, and ensuring everyone on the trauma team speaks that crucial common language.
It really provides that non-negotiable structure when you're faced with a critical injury. It guides you to assess and manage the most urgent issues first, based on proven, established principles. It truly is the foundation upon which effective trauma care is built worldwide, promoting those minimum standards and ultimately contributing to saving lives, just as the sources state.
And it's a framework that isn't static either. As the sources hint, it continues to adapt and evolve, right? With different additions and appendices addressing specific populations in complex environments like pediatrics, geriatrics, burn patients, mass casualties.
Absolutely.
And even linking out to broader concepts like injury prevention strategies.
Precisely. Knowing this structured approach gives any practitioner encountering trauma a roadmap, a reliable system to fall back on when the pressure is highest. It's fundamental.
So here's a thought for you to take away as you consider the impact of ATLS. given its role in building systems and promoting standards, and how the sources themselves connect this acute care framework to broader public health concepts like injury prevention, outlining strategies such as the 4Es, education, enforcement, engineering, and economics. How does mastering the principles of treating injuries in the moment, as taught by ATLS, position you not just to respond to the problem, but perhaps to contribute to preventing that massive global burden of injury we discussed at the very beginning?
That's a great point. Something definitely to consider as you apply these principles and continue your journey in medicine. How does fixing the immediate problem inform preventing it later?
Thanks for joining us for this deep dive into the Advanced Trauma Life Support Protocol. We hope it gives you a clearer picture of this essential framework and its importance in navigating the critical path of trauma care.